organizers and the chairpersons and obviously the audience. It's been a hectic day for you, and I think this is the last lecture of IRACON. So thank you for sitting through and waiting for my lecture. Thank you. So we'll be talking about back pain today and how a physician should approach back pain. Because as we all know, and this is going to be the structure or the skeleton of my talk, we'll be talking about the burden of low backache, the causes, various classifications, what to ask, when to ask, what are the red flag signs, how to and when to investigate, common conditions that cause back pain, how to treat them, and in a couple of interesting cases at the end. So we all know that backache is the commonest musculoskeletal complaint. Almost 50% of the rheumatology OPD consists of this complaint, and 70 to 80% of us have experienced back pain sometime during their lifetime. I don't think I know anyone who's not experienced back pain in their lifespan. It is a leading cause of disability and the most prevalent chronic pain syndrome, and tops the list on occupational disorders, and it's a global economic burden. There is a close relationship, reciprocal as well as, symbiotic relationship between mental health and back pain. People with back pain are generally depressed, and those with depression often suffer from back pain. But the good news is that almost 90% of the patients recover within 6 weeks, but up to 2/3 will still report some mild form of discomfort even up to 1 year. 1/3 of these patients will have recurrence even after recovery, and up to 10% will have a chronic disabling pain, and I am one of the patients of those kind. Only less than 1% will require surgery, so that's good news. That means 99% of the patients will recover or will manage their life with conservative management. Now this is the anatomy. I'm not going into details of the anatomy. We know that there is a vertebral body, the intervertebral foramen, the intervertebral disc. The discs have annulus fibrosus and a nucleus pulposus. We all know this anatomy, and I'm not going to go into the detail. Back pain can be classified in various methods, the most common being acute, subacute, and chronic. Acute, as I said, most of them recover themselves. It can also be mechanical or systemic. Systemic, mainly infections, neoplastic or inflammation, and specific neurological and non-specific. Now low backache, as I said, can be mainly mechanical or systemic. Mechanical can be spondylosis, disc herniation, spondylolisthesis, spinal stenosis, fractures, and non-specific. I'll go into a little bit of detail about each of these. And systemic can be either inflammatory, neoplastic, infection. There are examples of each of them in front of you. Metabolic, for example, osteoporotic fracture. Now, back pain can also be referred from an internal organ, for example, a prostatitis, cystitis, or pancreatitis, and miscellaneous and rare conditions like aortic aneurysm, dissection of the aorta, and rarely we get patients with psychosomatic back pain, malingering. Mind you, please do not classify everybody as a malingerer, because back pain is a real issue even if you cannot find the exact cause of it. Back pain in North India, everybody has a disc. So back pain is not disc, it's not disc herniation always. In fact, as I go through the slides, I showed to you that people with disc herniation, many of them do not even have back pain, and vice versa. So what to ask? The first and the most important thing you have to do in your practice is identify red flags. I'll be discussing red flags. Red flags are flags or symptoms that you must identify so that you can investigate those patients thoroughly, immediately, so that you can take action, because if you do not, the consequences can be devastating. Always look at the demographic, the occupation, if it's a male, female, age of the patient, if the patient is involved in hard labor or not. Inflammatory versus mechanical. This is a very interesting topic. I'll come to the differences. How do you differentiate whether this is a mechanical backache, if it's inflammatory or not? Always ask about radicular pain history. Mostly the radicular pain it's dermatomal. It causes leg pain, which is worse than back pain. It is a shooting, lancinating type of pain which radiates to mostly below the knee. The one that stays above the knee is generally not a typical radiating pain. And this radiating pain will worsen on coughing, sneezing, Valsalva maneuver. We have to differentiate two types of claudication, neurogenic as well as vascular. Now, vascular claudication happens due to atherosclerotic disease, and you will see that the patient complains that after walking a certain distance, the patient starts having leg pain, improves when the patient rests. Neurogenic claudication is mostly dependent upon the posture. So the patient, when walking uphill, has lumbar lordosis, the spinal canal becomes narrow, the patient starts having symptoms in the buttock, in the thighs, but the patient, when is flexed, like the patient is walking, uphill, the patient is flexed. I'm so sorry. When the patient is walking downhill, it's lumbar lordosis, so the patient has pain. But when the patient flexes, the patient has relief in symptoms. In vascular claudication, the patient will or might have decreased pulses, whereas that won't be there in neurogenic claudication. Always ask for a history of psoriasis, because that can give you a clue that this is inflammatory pain. Psoriasis even in the family is important. Even in the Casper criteria, the family history of psoriasis has a point. Always look and ask for uveitis, dactylitis and enthesial pains. Previous speakers have already well done that. Always ask a little bit about their mental health, what is going on in their houses, are they going through a tough phase in life which will worsen their symptoms. Now this is the red flag we are all worried about these days, but we are not talking about that today. If you have a patient with trauma, prolonged steroid use and age more than 50, think of fracture. A fracture needs to be investigated immediately. If you have a patient who gives a history of cancer or TB in the past, has an abdominal mass or previously, unexplained weight loss, is on immunosuppression, IV drug abuse is the history very common in northern part of India. Nocturnal pain, always think of infection and cancer, and this overlaps with the age there too. If you have a patient with neurological symptoms like bladder dysfunction, fecal incontinence, deficits and saddle dysthenia, we'll think of chlorhexidine. And if a patient is young, has significant morning stiffness, pain in the second half of the night, and pain at rest, even after the patient walks, comes and rests, has difficulty getting up after 1 or 2 hours, always think of inflammatory disorders like spondyloarthropathy. Now this is the differentiation between inflammatory and mechanical. Obviously you will find overlaps all the time in clinical practice, but basically mechanical inflammatory backache occurs in less than 40 years, has morning stiffness where there is no or minimal morning stiffness in mechanical backache. Inflammatory backache, as I said, increases with rest, but that improves with rest in mechanical kind. Inflammatory improves with exercise. The patient says, once I start walking for a couple of minutes, I start feeling better. Whereas that, at the end of the day, mechanical backache will worsen. CRP and other inflammatory markers might be raised in inflammatory, not in all cases, and patients might have alternating buttock pain and associated psoriasis, uveitis and other features. As mentioned by a previous chairperson very rightly, inflammatory back pain generally responds very well to NSAIDs. Mechanical backache also responds, but moderate kind, not very well. What to see? So obviously we have to inspect the patient, we palpate the spine. In inspection you can find scoliosis, you can tell the patient to bend down and you sometimes might find scoliosis. You check for spinal mobility, basic. We do a modified Schober's test that I'll show in the next slide. We do a straight leg raise test and a crossed SLR test. I'll explain why both. Look for a neurological deficit. Patient comes to you, might not understand what a sensory deficit is, might not report it to you himself. Always look if there is any neurological deficit. Look for hidden areas of psoriasis. The patients might have some itch in the navel, in the back of the ear, might not even report an itch. Always look for hidden areas of psoriasis, because that might give you a clue that this is psoriatic arthritis affecting the back. As mentioned before, dactylitis, enthesitis and uveitis must be looked for. At least you should suspect that in your OPD, so that you can work that patient up on the lines of inflammatory back pain. And most importantly, if the patient comes with backache, please examine the other joints, especially the hands, as I will show in one case which gave us a clue. Now this is the straight leg raising test and the crossed leg straight leg raising test. Very well taught in our MBBS days. So once you extend the leg and you raise the patient's leg passively between 30 to 70 degrees. If the patient has radiating pain going down that same limb, it is positive. Please remember, after 70 to 80 degrees, if you do that, anyone might have pain, so that is not significant. It is a very sensitive test, so it will pick up a lot of diseases, but it is not a lot of radiculopathies, but it is not specific. A more specific test but a less sensitive test is the crossed straight leg raising test. Now if you do the same procedure but the pain goes in the opposite limb, that is the crossed SLRT, and it's a much more specific test for disc herniation causing radiculopathy. Now this is the modified Schober's test. We all know that, we've done it in an OPD and hardly takes 1 minute. So you mark the dimple of Venus where the PSI is, you mark 10 centimeters above, 5 centimeters below, tell the patient to flex the back without bending the knees, and if the distance increases by more than 5 centimeters, it's fine. But if it's less, it tells that the back is stiff, and you should suspect an inflammatory back pain in a young patient if that happens. Now, how to investigate, when to investigate? Most importantly, in backache, please do not investigate indiscriminately. Any patient who comes to your OPD with backache, you do not need an X-ray also, because most of the time it's mechanical, most of the times it's acute, most of the times it's going to resolve. As I said, in 90% of the cases it's going to resolve within a few weeks. But if your clinical decision is dependent on it, and especially if you find red flag signs, please order investigations. Most common investigations done are X-rays and MRIs, but you must remember that the findings on X-rays and MRIs will not always, in fact mostly will not correlate with what the patient is describing to you. Sometimes you just might find a simple spasm, sometimes the X-ray might absolutely be normal and the patient still has bad pain. Sometimes the X-ray is so bad to look at but the patient is walking absolutely normally. So it goes both ways. Because if you order indiscriminately, you order an MRI for all of us and most of us will have some or the other disc herniations or protrusions, and then will be labeled as disc patients, especially in northern India. And more than 2/3 of the middle-aged adults will have degenerative changes in the spine. Not all of them will have any symptom at all. But if you are suspecting inflammatory back pain, order CBC, creatinine, SGPT, because you will have to give painkillers, and order inflammatory markers to confirm your suspicion. But again, let me clarify, in almost 40 to 50% of the patients, even with inflammatory back pain, even with spondyloarthropathies, the inflammatory markers may be normal. So that is just a clue. Please do not take it for granted that the ESR and CRP are normal. This patient cannot have spondyloarthropathy. Let's go through some conditions very quickly. Most common cause of back pain is lumbar spondylosis, which is degenerative changes in the spine, in the discovertebral and the facet joints. You can see disc or joint space narrowing, subchondral sclerosis, osteophytes I'll show in the next image. And as I said, imaging evidence will not always correlate with the symptoms and vice versa. Other features like facet joint degeneration, small nodes, mild spondylolisthesis and mild scoliosis may be present. So this is the typical image. If you see, there are osteophytes that you can see, there is subchondral sclerosis, and you see there is disc space narrowing. So this is a typical degenerative spine, and sometimes even in young patients you get these small nodes, which is the protrusion of the disc material into the vertebrae. It's quite normal to find these things on MRI, and you should not ascribe, as I said, the symptoms to the MRI or X-ray findings. This is a very badly degenerated spine of one of my patients. I just wanted to show the image. Disc herniation is the most common cause of radicular pain in young adults, but it is common even in asymptomatic adults. As I said, you do an MRI for many people will have disc herniations, not necessarily they'll be symptomatic. And as we know from anatomy, 75% of the flexion is at L5-S1 and 20%. So 95% of the flexion is between L5, L4 and S1. So 95% of the compressive radiculopathies happen at this level. And immediate imaging is again not required in all patients. Only if you find a significant neuro deficit, for example a foot drop, you have to do it, and or red flags, you have to do it. L4, L5 herniation will generally cause L5 nerve root impingement. This is for the medical students that wherever the disc herniation occurs, most of the time it suppresses the nerve below it, so below that level. So L4, L5, remember L5 will be affected. This is important for your examination when you examine the dermatomes that way. and a large midline disc herniation very rarely can cause chordoid-Weiner syndrome. Now this is a disc, if you see, this is a pictorial representation. Look at the neck of the herniated disc. It is narrow and then it becomes broad. This is called an extrusion, and if the base is also broad, then it's called a protrusion. And if it does not cross the annulus fibrosus, it is caused just a bulge, which is the most common finding on X-rays. You can see that on this image also, and you can see it here also. You can see it here. It's on the axial image, and this is the extrusion. Okay, so spondylolisthesis is caused by a defect in the pars interarticularis, where one of the vertebra moves ahead of the vertebra below it. It can happen early in life due to fatigue fractures. Runners can have it, but it can also happen in elderly with degenerative spondylolisthesis. It may be asymptomatic. You might do an X-ray for something else, you might find it, but if it's very severe, it can cause nerve root impingement and spinal stenosis. The spinal stenosis is caused by narrowing of the central spinal canal, which compromises the neural structures, and 20 to 30% again, maybe radiologically you must have done an MRI for something else. Spinal stenosis is found on MRI, the patient has no symptoms, don't need to treat it. But if the patient is symptomatic, the patient will complain of neurogenic claudication, which is pain in buttocks, thighs, legs, may have paresthesias as I explained, and it is relieved by bending forward. So it is increased. It's called the shopping cart sign. I'll show it in the next image. So when the patient is bending towards the shopping cart, the space increases, so the pain decreases, but when the patient is extending backwards, the pain will increase because the space in the spinal canal decreases. Such a patient will generally walk with a wide-based gait, and in very, very severe cases when conservative treatment does not work, we do a decompression surgery. So DISH, as mentioned by the previous speakers, is not an autoimmune disease. It's ossification in of the paraspinous ligaments. It happens in metabolic diseases. Because of this ossification, there is a flowing wax appearance on X-rays, and typically the SI joints are normal. The patient may be asymptomatic. So this is a typical picture of DISH. You can see the flowing wax appearance. It's a little different from spondyloarthropathy. I'll show the image of that also. Now, most, as I said, 85% of the times you cannot ascribe the pain to a typical pathoanatomic diagnosis, and that is what is called non-specific low back pain. In fact, most of the mechanical back pain is also non-specific, because what you find on the image you will not find in the symptoms of the patient, and this is caused by an interaction of biological, psychological and social factors. I've experienced neck pain during my exams even if my posture was right. Most of the cases of acute mechanical backache are non-specific and they will resolve themselves, and only 10%, as mentioned before, will develop into chronic diseases. But always rule out the specific causes. Just some images. These are infections. For example, this is TB of the So this is tuberculosis of the spine. Other infections like vertebral osteomyelitis, epidural abscesses can cause it. This is a prostate malignancy that has metastasized to the spine, and most of the times you will see that the patient has pain which is worse at night. It is not alleviated by rest. When you have a patient of backache, losing weight, anemia, please think of multiple myeloma. Order an ESR. If the ESR is very high, please get an X-ray or an MRI done. Metabolic diseases like Paget's and osteoporosis. So this is the typical wedge fracture that we've seen in our OPDs day in and day out. What to ask in inflammatory disorders? So in ankylosing spondylitis, if you are suspecting there is a family history of that, ask for uveitis, as I mentioned. Psoriatic arthritis, please do a thorough skin examination, hidden areas, nail changes. If the patient has GI symptoms along, think of IBD related arthritis. UTI and GI infections, think of reactive arthritis, and in children, juvenile onset SPA. Now this is a spondyloarthropathy, and you look, this is a T1 image showing some erosions here, but a stir sequence is showing a very good bone marrow edema which is bilateral. Treatment, bed rest is not recommended in either acute or chronic backache. NSAIDs, PCM and muscle relaxants are given in acute settings. In there are non-pharmacological methods. I'm not going into due to the paucity of time. Epidural injections can work only in disc herniation. Please do not prescribe for all backache patients. And there are some physiotherapy, TENS and other therapy. Even in chronic backache, bed rest is not recommended. Duloxetine is a good drug, especially it works in the mental level also, so people associated with depression will have a good response to it. Non-pharmacological methods are good. In chronic backache, please advise the patient core strengthening exercises. This surgery, again, there is insufficient evidence. And if you find a systemic cause, please treat the systemic cause. Now, this is an algorithm which is very easy to understand. If the patient has red flag signs, ESR is high, consider an X-ray, MRI if required, specific treatment if you get the disease. If the patient has neurological signs, if they are like, please get an urgent consultant, an MRI. If there is radiculopathy without any serious neurological deficit, please wait for 4 to 6 weeks. But if you have spinal stenosis, again, if it's not serious, you can be conservative about it. And patients with non-specific backache, please do conservative management, but they do not improve within 6 to 8 weeks, you can go ahead with investigations. A couple of short cases. This is a patient who walked into my clinic, and this is how the patient could not bend. I do not even need to do a Schober's test in this patient. And this is the spine of the patient. Look how the syndesmophytes are forming. This is a normal SI joint X-ray that I've just for comparison, and this is the X-ray of that patient. Look at how fused the SI joints have become. This is another sign. This is not that patient, the next patient, but another sign on MRI that you can pick up in early inflammatory spine diseases. And look at this. This is the shiny corner sign or the Romanus lesion. Not specific, but in the right setting, if the patient is young, inflammatory back pain is suspected, and you find it, this patient must be starting to develop inflammatory arthritis of the back. Spondyloarthritis. 65-year-old gentleman with inflammatory back pain for many years. As I said, you must examine all other joints. Now this hand looks okay, but look at this hand. The DIP of the middle finger is bent, and please focus on the index finger. The index finger looks a little thicker than the other fingers. This is dactylitis. So as mentioned in the previous talks, dactylitis is suspicion of inflammatory arthritis, especially psoriatic. Now I zoomed in on the nails of the patient, and look at what I found. There are small pits on the nail of the patient, and even on the other side there is some hypertrophy under the nail bed. And lo and behold, you expose the patient on the back and you find psoriasis. So always look for other joints and other small clues that will help you make a diagnosis. In a 65-year-old, you won't expect an inflammatory back pain, but it was there. The take-home messages are: please take a proper history, identify red flags, examine very short things, Schober's test, SLRT, cross will take only 2 minutes. Order imaging only if you suspect a systemic cause. Imaging findings may not correlate with what you find, and conservative management will work in 99% of the cases. What the mind does not know, the eyes cannot see, so you have to know before you examine the patient. This is where I work, and I come from the city of Golden Temple. I hope to host IRACON someday there. Thank you.
Excellent talk, Dr. Swapan. I think you covered almost everything. One important thing which I felt was this talk was one non-inflammatory, non-infective, non-mechanical cause of back pain. Fibromyalgia. Yeah. So that is one important thing, which is mostly psychogenic, psychosomatic.
Yeah, I think that will probably come in non-specific.
Yeah, non-specific. Yeah, but it is generalized. Generalized spread all over.
Agreed, sir. Point well taken.
Second thing, can you go back to your shopping cart picture?
Yeah. Yeah. Yes.
So, forward bending, actually, the canal improves. So patients go forward in the stenosis.
Yes, I got confused in the first part, but forward bending improves, so the patient tends to bend on the shopping cart.
And in disc pain, sometimes you see, as you mentioned, that this may be normal, but the patient has radicular pain. So can you explain how it happens in the initial, without any mechanical compression of the nerve, how it happens? There is no mechanical bulge of the
There is
nerve.
a sclerotomal pain can happen, and I mean, it generally does not go below the knee.
No, it goes. Sometimes you have classical radicular pain, but then the spine MRI looks normal. What you see, if you see carefully, you will have something called as internal disc disruption, what we call as IDD, wherein the nucleus pulposus, your diagram I was seeing, nucleus pulposus, it comes to the area of annulus fibrosis because of internal rupture of the internal fibers of annulus fibrosis.
Yes.
Now, if you know, the nucleus pulposus is totally separate from the immune system. So once it touches the annulus fibrosis and the blood supply comes over there, then there is an inflammatory response, cytokines are secreted, and that causes the pain.
And it can
So that explains your some of the mechanical discogenic pains being relieved partly by anti-inflammatory drugs.
A few more. Brucellosis is also seen. I have seen a few cases of brucellosis and patients with pyrexia of unknown origin. And usually on the MRI, these abscesses are very small. Okay. They can peak in the liver, but they can be small in the spinal as well. And people can have cross positivity with tuberculosis, typhoid, things like that. The other thing is this eosinophilic granuloma, sort of, and ENETs. These are rarer causes of the backaches, which can be the sinister backaches. Thank you very much. It was a good talk.
Lifestyle modification would be the one.
So I do it myself. I have been a patient for the last 12 years. I do not sit on very soft sofas. I do core strengthening exercises every morning. I do not bend to pick up things. I bend my knees, I squat, and then I pick up things. And good food. Don't let your weight increase. Keep it below your, for your normal BMI, and that's about it. So, no smoking.
Actual indication for the spine surgery.
Absolute indication for the
Spine surgery.
spine surgery. If, for example, if the patient has a severe motor deficit, you have to go ahead with surgery, because whatever you do, once the motor deficit is complete, you won't be able to revert it with conservative management.
Commonly I see is mechanical back pains. Being a physician, the most common cause is driving in the traffic.
True.
So,
Bangalore especially.
yeah. So Bangalore is very common there. Do you have any suggestions how do we posture ourselves in the driving?
I use a pillow in my car, which is a lumbar pillow. It's available online. It's a cylindrical lumbar pillow that I use. But when I go for long drives in Amritsar, that's not a problem for me. But when I go on long drives, every half an hour I'll get up, stop the car, walk around.
We can't stop in Bangalore.
That's
We are in the same place for a long time.
It's a common problem. This is one of the lifestyle disorders now. The aches and pains because of our busy lives.
And also the software people, they know they
many people.
Work from home has become another big problem.
Absolutely. Even thumb pains.
Especially the handhelds and the laptops.
Absolutely.
So the curves of the spine have been altered. The cervical lordosis, the lumbar lordosis is gone. Everything becomes kyphotic. So, and the sir was asking about the surgery absolute indication. Spinal surgeries, sir will also tell. Cauda equina syndrome is something which we should never miss. So, and the patient can have sometimes without motor also, they can have no motor deficit. So, severe leg pain, not responding to conservative treatment for a long time is the indication for surgery. Usually for 6 weeks you can wait. And in UK, if somebody has got numbness or weakness also, they are put on the waiting list. But cauda equina is number one.
Yes.
But motor weakness also, our patients do not tolerate. If somebody has a foot drop, so they would want to have the surgery done here. So it's a different scenario. And there are other things like spondylolisthesis, backache where the symptoms are lasting more than 3 to 6 months. Those are the things, and it should be disabling backache.
Yes.
So disabling backache, those people who require medications regularly and they are not helped with any of this, those are the absolute indications for mechanical backache. And radiculopathy, as sir told, neurogenic backache, severe leg pain not responding.
And he can have minor
weakness,
backache.
weakness of the EHL, ankle dorsiflexion, need not be foot drop, need not be to the extent of foot drop. We don't wait for foot drop to come and then do the MRI. If there is EHL grade 3/5, definitely do an MRI, because there may be a large disc which will not heal ultimately. Grade 3, grade 4 discs do not heal usually. Grade 1 and 2 they can heal. But if you have a progressive deficit, progressive numbness, it's a precursor of CODA. Second is, there is also something called as a chronic CODA. Chronic CODA syndrome is commonly seen in cases of lumbar canal stenosis. They have progressive neurogenic claudication. The claudication distance reduces progressively from 1 kilometer to up to 100 meters also. And then if you check their post-void residual urine, that will be a high. Okay, if the post-void residue is high, we fail to check post-void residue in many patients with lumbar canal stenosis. And if it is high, it is called as chronic CODA. That means they need surgery.
Occasionally, when we look at MRI, we find the type 2 body change. Any reaction it will make in the treatment of the patient?
Degenerative modic changes are absolutely no indication for surgery, means per se. If there is a neural compression causing neurological deficit, then only. Even if there is radicular pain, it is not an absolute indication of surgery. Neurogenic radicular pain not responding to medications, as sir said, for a long time, leading to neurological deficit, then yes. But we don't treat the imaging.
I specifically removed that slide. I had a slide and images of modic changes, but because that is not going to change our management, it's not very relevant.
We don't treat MRIs, we have to treat the patient. And when we see the radiological report and when they make it cold, patients do get, in fact, they get psychotic. So they come back and they say, I have all the discs herniated. It's not. What is clinically significant is what the clinicians do.
Normally we say type 2 body change on the level when we have the pathology.
Sir, they have done studies where they have done MRIs, routine MRIs for people who don't have backache. And in that the incidence of disc problems is more than 30 to 40%. So we should factor this in mind when we counsel our patients. So that's what I tell them. They come with a lot of reports. We do tell them that, well, as you have graying of hair, you can have similar changes in the spine also. Okay, so don't be alarmed about all the things written. We need to, so I usually take them, read them step by step and tell this one not to be bothered, not to be bothered, not to be bothered. This is the only one which might likely to be causing you the problem, is how I usually counsel them. But if you see, most of the people who don't have backache, if you do 33 to 35% to 40% show some changes or the other.
Actually, I attended a World conference on back pain. There was a doctor from Denmark. She said that if you have a type 2 body change, you should give her antibiotic work maybe 4 to 5 months. Are you aware of that?
What an antibiotic?
Antibiotic for type 2 body change.
Yeah, I mean, see, there is a study from Ganga Hospital in Coimbatore. Dr. Rajshekaran has done this one. They have done, they have sent these discs from the disc surgery for microbiological evaluation, and they have found some organisms, not the common organism, but there is some evidence that the initiation of the slip disc may be due to an infective cause. I think it was awarded the Golden Pepper Award of one of the Spine Society meetings. Dr. Rajshekaran from Coimbatore has done. So, but it's still not, so an infection, some clinical infection along with the mechanical cause may be the cause of disc. Why should lots of people do hard work, but why does everybody not get a backache? So there might be some role, but we still don't have much clarity about that at the moment.
I have about 100 patients.
Thank you, sir. Thank you, so much, sir. We are running short of time actually.